So good morning, everybody. So I'm going to talk about brainstem death, assessment and declaration, and briefly about the management of brain dead organ donor. So brain death basically means irreversible loss of all the function of the brain and the brainstem. So a patient, if he is brain dead, that means he is legally and clinically dead. And nowadays, I think even the laymen are more aware about the concept and they're more accepting of brain death than what it was previously. So in India, Transplantation of Human Organs and Tissues Act, that was in 1994, first time recognized brain death. But this is only in the concept for organ donation. So only in the context of organ donation, they have defined the brain death. So if the patient is not going for organ donation, as in our Indian setup, there is no proper legal way to go about it. So only in the context of organ donation, they have defined. So who should diagnose brain death? So team of 4 medical experts are required. So one has to be the medical administrator in charge of the hospital. Then other has to be authorized specialist. They can be intensivist, anesthetist, physician, surgeon. The other has to be an authorized neurosurgeon or a neurologist. And then the medical officer treating the patient, or the primary physician treating the patient. So in Karnataka, we have what we call Jiva Sarthakate. That is the panel where we have to report the brain death to. So the panel should have approved the specialist and the neurosurgeon or the neurologist. So there is a modification they brought about. If there is no availability of neurologist or neurosurgeon, the specialist itself can declare the brain death. So basically brain death, it is a clinical diagnosis. So you don't need, if you do a proper clinical examination, that is 2 assessments should be done of the brainstem reflexes and apnea test. So after that, you do not need any other tests. You can declare the patient as brain dead. So in India, we follow the UK criteria for brainstem death. So how do we diagnose? So basically, first of all, there should be some etiology which will explain that the patient can go into brain death. So example can be hypoxic brain injury, a large icy bleed, severe traumatic brain injury, sometimes acute liver failure leading to cerebral edema. So some etiology should be there for the brain death. So after that, you should make sure that there are no confounding factor which will mimic a brain death. I'll come to that. And then you have to do a thorough neurological examination and make sure that the patient is in coma. There should be absence of brainstem reflexes and the apnea test should be positive. Okay, so what are these confounding factors? So the patient should not be under the influence of alcohol or any drugs which depress the CNS or muscle relaxants. Primary hypothermia, we may not see that much here in India. Hypovolemic shock should not be there, and any metabolic or endocrine disorder should not be there, or electrolyte imbalance should be ruled out. So all these things should be ruled out. So once that is done, we have a certain prerequisites. So we should make sure that the core body temperature is at least 36 degrees Celsius before going ahead to test the brainstem reflexes. And a systolic blood pressure should be more than 100 millimeters of mercury. So we can stabilize the patient with fluids, vasopressors, make sure that the BP is okay, then go ahead with the testing. Also, the eucapnia should be there with a PCO2 of 35 to 45. So once you ascertain all this, then we have to make sure that the patient is in coma. So you have to give a noxious stimuli and look for motor response. So you can give a supraorbital pressure, or temporomandibular joint pressure, or nail bed stimulus and look for any motor response. Motor response can be usually in these patients like flexion, abnormal flexion, extension, something like that we have to look for. So once if that is not there, then we have to go ahead and test for brainstem reflexes. So pupillary reflex is what we look for. So basically here in the brainstem reflexes, we are testing all cranial nerves except olfactory, spinal accessory and the hypoglossal nerves. So other nerves are all tested. So pupils, we have to make sure that the pupils are unresponsive to light. always it may not be fully dilated. Sometimes it might be in a mid-dilated position. Sometimes it might even be unequal, but the criteria we're looking for is it should be unresponsive to light. And then corneal reflex, jaw jerk, and pharyngeal reflex, where in an intubated patient, what you do is you use a tongue depressor and look for the pharyngeal movement on both sides. Sometimes it might be difficult, so if it's not possible, it's okay if you don't do it. Then cough reflex, by the suction catheter you have to pass and like look for any cough. And then oculocephalic reflex and oculovestibular reflexes. So oculocephalic reflex is like what also we call as doll's eye. So before doing this, we have to make sure that the patient doesn't have any cervical spine instability. So after that, you have to hold the eyelids open and rotate the head from side to side. So in a brain dead patient, what you will see is eye will be fixed to the center. The eyeball does not move. Normal response will be when you move to the right, the eyeball will move to the left. But you don't see that in patient who is brain dead. So after that, the cold calorie set test or vestibular ocular reflex. So here the patient has to be kept 30-degree horizontal position, and 50 cc of first they should make sure there's no tympanic membrane perforation, and then inject cold saline into the inner ear canal. So you have to look for any eye movement for about a minute's time, and you have to do it bilaterally. Between the two sides, you have to give a time gap of 5 minutes. So you do on one side, wait for 5 minutes, and then check on the other side. So once you make sure that there are no brainstem reflexes, then you go ahead and do the apnea test. So the basic concept of apnea test is to look for the build-up of, like what you do is you build up the carbon dioxide and you try to stimulate the respiratory center and look for any respiratory movement. So if there's no respiratory movement, then we call it apnea test positive. So how we do it is, we pre-oxygenate with 100% oxygen, say for about 10 minutes. Then we disconnect the ventilator. So you should have a baseline ABG first with a normal PCO2 levels. And then you place a catheter inside at the level of the carina, and oxygen can be given at a rate of 6 liters per minute. And then after that, you have to wait and look for any respiratory movement. So when you're doing the apnea test, if you all have done, it feels like very, very long. You don't feel it's 10 minutes because you just have to wait and watch for respiratory movements. So after 10 minutes, what you can do is you can take an ABG sample, okay? And what you have to look for is the PCO2 should be more than 60 or 20 millimeters of mercury above the baseline. So if you see this, then you say the apnea test is positive. So during the test, if you see any respiratory movements, then that means which is generating tidal volume, then it means that the apnea test is negative. So if you're not able to complete the test for any reason and the PCO2 does not go up more than 60, then that means it is indeterminate. So sometimes what you see is after 10 minutes, your PCO2 is still not high enough. It may be 50, 55. So if the patient is stable, we can wait for some more time if we have not connected back on the ventilator. So it's better not to connect back on the ventilator immediately after you take the ABG. You wait for the ABG if the patient is stable, because you can extend the test for some more time and see if your PCO2 builds up. Okay, as long as respiratory movement is not, then PCO2 is building up. Even if it's after 10 minutes, we can say apnea test is positive. In a patient who's hypoxic, some modifications can be done, like some amount of PEEP can be given so that the patient does not desaturate. That is one of the modifications that we can do. So, so during the apnea test, we have to be careful. We have to make sure that the patient is not becoming unstable, the BP does not drop, or the saturation does not drop, or there are no arrhythmias. We should make sure that the patient doesn't have a cardiac arrest. So some special consideration in patient with severe lung disease, like the baseline CO2 itself may be very high. So then your PCO2 we may not know the baseline CO2, and sometimes like whatever PCO2 we are getting may not be enough to stimulate your respiratory centers. In that case, we might have to go for an apnea test. But if you know the baseline CO2, you keep like more than 20 above the baseline CO2, and you can do the apnea test. So if the patient is undergone targeted temperature monitoring, you have to rewarm the patient and wait for at least 24 hours after that to do the test. And if the patient is on sedation, we at least wait for 5 half-lives for the sedation to wear out before doing the test. So there are some observations which are compatible with the brain death. So basically, if you see the patient sweating, flushing, tachycardia, these things still mean the patient is brain dead, doesn't mean anything. Sometimes deep tendon reflexes can be there, superficial abdominal reflexes, then triple flexion, that is flexion at the hip, knee, and the dorsiflexion at the ankle, Babinski's sign, and Lazarus sign. Lazarus sign is sudden extension of the arm and drop on the chest, what you can see. So these Lazarus sign and the spinal reflexes can be seen during the apnea test, because the hypoxemia and some hypotension, if it is there, that can stimulate this. Okay, so in case you're making the family stand around you when you're doing the test, you have to inform them that these things can be seen, which still means that the patient is brain dead. So this test should be done twice, at least 6 hours apart, and then only we can declare them brain dead. So once we declare, we have to notify the next of kin, and also certification and documentation of the brain death is important. We have this Jiva Sarthakate, where we have these forms which we have to fill and submit. So as per the Indian law, only the clinical test is described. So they don't have anything about the ancillary tests. So ancillary tests we do when we are not able to do the apnea test for any reason, or there is any doubt regarding the diagnosis. So then we do the ancillary tests. So ancillary tests, there are tests to assess the cerebral blood flow. So here we're looking at absence of blood flow, and then some tests to look at the cerebral electrical activity as well. So out of the tests we have, nothing is ideal. Everything has some drawbacks. So out of them, the gold standard is 4-vessel cerebral angiography, where we look at the opacification of the 4 vessels, that is the 2 carotid and the vertebral arteries as they enter the skull. So if there is no blood flow, then we can say that the patient could be brain dead. But there are multiple difficulties, like this is done in a cath lab, so it may not be sometimes feasible to go ahead with this. And then there's something called stasis filling, that is some filling of the vessels can be seen, because some slow flow will be seen, which doesn't really mean there is any blood flow, so that has to be kept in mind. And all these techniques which assess the blood flow to the brain, if the patient has undergone decompressive craniectomy or has some EVD insertion, then it might be difficult to assess. So other tests is like radionucleotide imaging can be done, something called where this isotope is not taken up by the brain parenchyma, something called hollow skull phenomenon. Other this thing which can be done is your transcranial Doppler, which is a bedside test, and more people are doing this. So here what you can see, the first one is a normal TCD waveform. So from B to E is like what are the waves which can be seen in brain dead. That is, in B you see that diastolic velocity is very low, then there is zero diastolic velocity, then there is reverberating flow and short systolic spikes. So these can be consistent with brain death. But there are certain advantages and disadvantages of transcranial Doppler, like it is easily performed, portable, and not expensive. Posterior circulation also can be visualized, but limitations can be in 10% of the patients, the window may not be adequate. There might be inter-observer variation, and also like the problems with assessing the blood flow techniques like the decompressive craniectomy and all that might alter this. So if you're doing a TCD, at least twice it should be done 30 minutes apart. Then CT angio and MR angiogram also can be done to look at the blood flow. Then the other test is the EEG. So here we are looking at the electrical activity. So we should do at least for 30 minutes. So if there is the problem with EEG is there can be multiple artifacts. Okay, so that can give you a false negative test. And if the patient is under some sedation or TTM, then false positives also can be there. And evoked potential also can be done. Okay, so this is about the brainstem testing and declaration. So briefly about the management of brain dead organ donor. So it is very important to identify the potential organ donor, brain dead donors. So if you identify early, it makes things very easy to go ahead. So, and we have to manage them, we shouldn't think that, oh, patient is brain dead, we don't look at this patient. Actually, we have to take extra care of these, because they can be organ donors to other people, and then we'll be saving more and more lives. So what happens in brain death is, basically there's raised ICP, which will reduce the blood flow. So initially you will see this bradycardia, hypertension. Then as it progresses, there'll be some catecholamine storm, which can cause tachycardia, hypertension. And then finally you'll see vasodilatation, hypotension, bradycardia. So basically what is happening is multiple, you'll see different instabilities. So that is what you see in the cardiovascular system. So pulmonary changes, it can lead to neurogenic pulmonary edema, mainly because of the catecholamine surge itself. And there can be some endothelial damage and capillary disruption. And you'll see endocrine changes because of the failure of the hypothalamic pituitary axis. So common thing, what we should all, I think most of you will be aware about, is diabetes insipidus. So these patients will have diabetes insipidus, and criteria is there. So the polyuria with urine output of more than 2.5 to 3 ml per kg per hour. And then there will be dilute urine. So urine specific gravity will be less, osmolality will be less. Hypernatremia with a sodium of more than 145. So this diabetes insipidus is pretty common. It will be seen in around 46 to 87% of the patients with brain death. So other thing is, there can be reduction in the free triiodothyronine levels, hyperglycemia, adrenal insufficiency. And you'll see that there is a big inflammatory response, mainly because some mediators released by the damaged brain, which can cause inflammatory response. And necrotic brain tissue will also release some tissue thromboplastin and plasminogen activators, which can cause DIC-like picture. And you'll see hypothermia also, because of suppression of the HPA axis. So these are the different changes that we can see during the brain death. So how we manage is, so hemodynamic management is very important. So adequate volume expansion should be given with crystalloids. So if the patient has a diabetes insipidus, then you might have to give a half normal saline. Where patients may require vasopressors as well as inotropes. So patients will have vasodilatation, and considering the DI also, first choice will be vasopressin, and then you can add noradrenaline along with that. If there is cardiac dysfunction, your other inotropes also can be used. And other thing you have to remember is, we have to stabilize the patient. So we will have to, if the patient doesn't already have an artery line, central line, we have to insert this and stabilize the patient, like how you'll stabilize any other patient. Hormone supplementation. So especially if the patient is hemodynamically unstable or the cardiac contractility is not good, then we have to go for hormone supplementation. So vasopressin we have to give at its dose is 1 unit bolus, followed by infusion of 0.5 to 4 units per hour. Hydrocortisone 300 mg stat, followed by 100 mg TID. Previously they were giving methylprednisolone high dose, but because of the multiple complications, infections and all that, the evidence now is more in favor of hydrocortisone. Insulin to maintain a normal blood sugar level, and thyroid hormone supplementation, especially if the patient is hemodynamically unstable. Regarding the hormone supplementation, there is no proper consensus, but with hemodynamic instability, most of the people would want to give hormone supplementation. So management of diabetes insipidus. So IV fluid should be given to replace the fluid loss. Hypotonic solutions like 4.45% saline and 5% dextrose should be given. Sodium level should be targeted between 135 to 145. And desmopressin or vasopressin can be given. If patient is unstable, prefer vasopressin, otherwise desmopressin. Desmopressin, I think there's some problem in availability also. Respiratory system, lung protective ventilation. So patient may be in ARDS kind of picture. Then you might sometimes even have to prone the patient. Okay. Hypothermia should be, most of these patients will have hypothermia. Prevention is the best thing to do than once patient goes into hypothermia, you try to get it back. It's better to prevent. Then other management like anemia might be there, that has to be corrected, like how you correct, like 7 is a transfusion target, correction of coagulopathy. Make sure that there is you prevent infection as much as possible. If there is some infection, treat it. Nutritional support also should be given. Arrhythmias, if present, should be treated, like amiodarone can be given, cardioversion. Atropine, because the vagus nerve is not working, so basically cannot be used to manage bradycardia. So in some of the brainstem testing it is used, no response to atropine. So that is one of the things. So we can give adrenaline, isoprenaline or pacing. So to summarize, brainstem death is a clinical diagnosis. So first, an etiology should be there for brain death. The confounding factor should be ruled out, and then elicit coma, absence of brainstem reflexes, and positive apnea test. Ancillary test should only be done when the clinical diagnosis is doubtful or apnea test is not positive, not confirmatory, not otherwise. Out of the ancillary tests available, cerebral angiography is the gold standard. Then early identification and appropriate management of brain dead organ donors is very important. Thank you.